While going through KDIGO 2025 guidelines on nephrotic syndrome in children, I could not find major differences between KDIGO 24 and 25. Hence, I've summed up the two guidelines together, making a common algorithmic approach to any case of nephrotic syndrome you might encounter in your practice. Along with, I've added reminders or revisions to important concepts and have highlighted the few new recommendations by the end. So it's best you watch the video throughout. I've also added case scenarios in the end for better understanding. Starting with the algorithmic approach, if you find a patient with edema which is predominantly periorbital or generally anasarca in most cases, or an incidental laboratory confirmed hypoalbuminemia, which as per KDIGO should be less than 3 grams per deciliter, along with this you find an evidence of proteinuria, which is spot urine protein creatinine ratio more than equal to 2 gram per gram, or 24-hour urine protein more than equal to 1000 milligram per meter square per day, or urinary dipstick value more than equal to 3 plus, then in that case you label the patient as having nephrotic syndrome. In most of the cases, we are using this value, spot urine protein creatinine ratio or urinary dipsticks. Tests like heat coagulation test and sulfosalicylic acid tests have not been recommended by the KDIGO, which we commonly use in our wards. So in that case, you look at three things: age, family history, and syndromic features. Age of the child can either be less than 12 years or more than 12 years. If the age is less than 12 years, you do a renal biopsy only if there is a positive family history of nephrotic syndrome, if the child has syndromic features, or the child is suffering from a congenital or infantile form, that is less than 1 year of age. However, if the child is more than 12 years of age, then you definitely have to do renal biopsy before starting the treatment. Start treatment with prednisone or prednisolone. Prednisone is the inactive drug, inactive prodrug, and prednisolone is its active form, which is formed by in the liver, and it is started at the rate of 60 milligrams per meter square per day or 22 milligrams per kg per day for 4 weeks or 6 weeks, followed by alternate day dosing of 40 milligram per meter square or 1.5 milligram per kg for 4 weeks or 6 weeks. With this, the patient can go into remission or the patient may show resistance, which we'll talk later. A patient in remission can show complete remission, which is defined as first morning or 24-hour urine protein creatinine ratio less than equal to 200 milligram per gram or 0.2 gram per gram or 20 milligram per millimole, or negative or trace dipstick or less than 100 milligram per meter square per day urine protein in 24-hour urine sample on 3 consecutive or more days, or the patient will show relapse. The relapse is simply you define relapse on dipstick only, which is urine dipstick more than 3 plus for 3 consecutive days. KDIGO also defines partial remission, which is first morning or 24-hour urine PCR more than 200 milligram per gram but less than 2 gram per gram. And if available, serum albumin will be more than 3 grams per deciliter in this patient. However, the KDIGO fails to explain and approach the management of these patients in partial remission, which is often seen in patients who have infection associated relapses or who are non-adherent to therapy. So a clear-cut guideline on this aspect is missing, and I request if anyone is very clear about how to manage these patients on partial remission, please do mention the same in the comment section below. Initial remission is seen in around 80 to 85% of patients. So this will be in around 80 to 85% of patients with idiopathic steroid sensitive nephrotic syndrome. But the thing is that around 51% cases only will show a sustained response. The rest around 49 to 50% would relapse again. So they will fall into this category. So this uh, figure is important in prognosticating the patients. A patient with relapse can have infrequent relapsing nephrotic syndrome or can be a frequent relapsing nephrotic syndrome, which is defined as more than equal to 2 relapses in first 6 months following remission of the initial episode, or more than equal to 3 relapses per 12 months in any subsequent 12-month period. Now, this is the minor change which they have done. In 24, they said they made this value of more than equal to 4. In 25, they say more than equal to 3 relapses in 12 months in any subsequent 12-month period. or the patient can have steroid-dependent nephrotic syndrome, which is 2 consecutive relapses during recommended prednisolone therapy for first episode, or relapse on tapering, or within 14 days of discontinuation of prednisolone therapy. If the patient has infrequently relapsing nephrotic syndrome or has frequently relapsing nephrotic syndrome without steroid toxicity, you restart treatment with prednisolone at the rate 60 milligrams per meter square daily or 2 milligrams per kg per day until remission for 3 consecutive days has been achieved, followed by 40 milligram per meter square or 1.5 mg per kg alternate day for 4 weeks. Here this is a difference. Like in initial episode, we can give alternative therapy for 4 weeks or for 6 weeks depending on how long we gave the daily prednisolone therapy. But in relapses, this alternate day therapy is mentioned only for 4 weeks as per the KDIGO. In patients of frequently relapsing nephrotic syndrome having steroid toxicity or patients with steroid dependent nephrotic syndrome, you would restart treatment with prednisolone at the rate 60 milligrams per meter square per day or 2 mg per kg per day until remission for 3 consecutive days, but this is followed by the addition of a steroid sparing agent along with 40 milligram per meter square or 1.5 mg per kg alternate day steroids, which should be overlapped, the two steroid sparing agent and this low dose steroid alternate day steroid should have a minimum overlap of at least 2 weeks, followed by tapering of the low dose steroid and continuation of steroid sparing agents. That is, even if you are using steroid sparing agents, you have to achieve remission with prednisolone only. Talking about resistance, if a patient has resistance, he is labeled as steroid resistant nephrotic syndrome. In this is defined as lack of complete remission within 4 weeks of therapy with daily prednisone or prednisolone at standard dose. Now here I would like to mention another thing. Like both KDIGO 24 and 25 say that the period between 4 to 6 weeks is known as the confirmation period, and if a patient who fails to respond to steroids within 4 weeks does respond between 4 to 6 weeks, he is referred to as late responder. But as per these guidelines in 25, steroid resistance should be labeled at the end of 4 weeks itself, and continuation for 6 weeks is not necessary as per these guidelines. This is what I infer from this. Nevertheless, if a patient with steroid-resistant nephrotic syndrome has presented to you, you would go for renal biopsy if it has not yet been done. Along with this, you will do genetic testing, the implications of which I will be discussing subsequently. You should start treatment with RAS inhibitors, and supportive management should also be done aggressively. Here I would again like to mention that steroid-resistant nephrotic syndrome is quite less common in children, and RAS inhibitors are more or less not indicated in children. The only thing the only one which I feel can be given is losartan. Telmisartan is not recommended in less than 18 years of age. Along with this, you should start treatment with calcineurin inhibitors. Now, these have become the norm in managing patients with steroid-resistant nephrotic syndrome, especially in adults. On the basis of response to calcineurin inhibitors, this steroid-resistant nephrotic syndrome can be CNI sensitive SRNS, or it can be CNI resistant SRNS. And if the patient is CNI resistant SRNS, then in that case the only options left for the patient are lifelong dialysis maybe, or renal transplantation. That is why kidney diseases are becoming very common. We see most of the celebrities suffering from some of the other kidney disease, and this is the course basically. If they are having resistance, then you go on to calcineurin inhibitors, and if resistance to calcineurin inhibitor is also seen, then you go for dialysis or renal transplantation. Some important reminders about the definitions of steroid resistant nephrotic syndrome. CNI responsive or sensitive SRNS is partial remission with 6 months and or complete remission with 12 months of CNI at adequate doses or levels. CNI resistant SRNS is absence of partial remission with at least 6 months of a calcineurin inhibitor at adequate doses and or levels. Monitoring calcineurin inhibitor levels is very important. I shall be discussing subsequently. MDR-SRNS is absence of complete remission with 12 months of treatment with two mechanistically different glucocorticoid sparing agents at standard doses, that is, whose mechanism of action is different. And secondary SRNS is a patient of steroid sensitive nephrotic syndrome who had initially shown some response to steroids, but later when he relapses, he does not achieve remission with steroids. So these patients are referred to as secondary SRNS. Maybe more guidelines would be coming up discussing or detailing management of MDR and secondary SRNS with drugs as more and more drugs are discovered. A word about steroid sparing agents, since increasing emphasis is being placed on them. Calcineurin inhibitors are the steroid sparing agents of choice nowadays and should be continued for at least 12 months. Trough levels of these drugs should be monitored and they have a high potential for nephrotoxicity, so renal functions also need to be monitored. Cyclophosphamide is given only after remission with steroids. Rather, this is true for all these steroid sparing agents. But what is important to remember is that you cannot repeat a course with cyclophosphamide or any alkylating agent for that matter. And weekly complete blood counts have to be done to monitor immunosuppression. Levamisole is given for at least 12 months and with alternate day low dose steroids. With this, you have to monitor CBC every 2 to 3 months, ALT, AST every 3 to 6 months, and ANCA, that is anti-neutrophilic cytoplasmic antibody, every 6 months. And in case the patient becomes ANCA positive, you'll have to stop treatment with levamisole. MMF is given again at least for 12 months. In severe abdominal pain, you may use MPAA, that is mycophenolic acid analogs, and target area under curve should be more than 50 micrograms per hour per ml. This is a unit for the same. Rituximab. Rituximab, the indication is very specific. It is frequently relapsing nephrotic syndrome despite optimal steroid and steroid sparing therapies. CD20 levels if available should be monitored, and immunoglobulin G levels should also be monitored, because we know the mechanism of action of rituximab is a monoclonal antibody against CD20, a B cell marker, which leads to humoral immunosuppression. Since CNI are so important, I think we must know about them in detail as well. Cyclosporin should be initiated in a dose of 4 to 5 milligrams per kg day, initially BID. It is preferable in patients with at risk for diabetic complications. The target 12-hour trough levels of 60 to 150 nanogram per ml or 50 to 125 nanomole per liter, aiming for lowest levels to maintain remission and avoid toxicity. Lowest levels mean somewhere close to 60 or 15 as per the units. Tacrolimus is started at a dose of 0.1 mg per kg per day, initially BID. It is preferred over cyclosporin in patients with unacceptable cosmetic side effects. The target 12-hour trough level is 5 to 10 nanogram per ml or 6 to 12 nanomole per liter, aiming for lowest levels to maintain remission and avoiding toxicity. So the choice of steroid sparing agents, and this has been mentioned in KDIGO 25, in patients with FRNS, oral cyclophosphamide and levamisole should be preferred. In SDNS, mycophenolate, mofetil, rituximab, CNIs, and to a lesser extent oral cyclophosphamide should be preferred. And in patients with SRNS, CNIs are the drugs which should be preferred. However, in most of the studies I looked on the websites, including PubMed, I found a high rate of relapse with MMF and limitations with cyclophosphamide and levamisole. So in future, there might be a recommendation that CNIs are recommended for all categories. Let us see with future research. For relapse prevention, frequently relapsing or steroid dependent nephrotic syndrome. Last time in last video also on KDIGO 24 I had mentioned this, that every steroid dependent nephrotic syndrome in a way will behave as frequently relapsing nephrotic syndrome, because as soon as the patient will show a response to steroids, but as soon as you will start tapering it, the patient will relapse, and this will lead to frequent relapses in that patient. So for relapse prevention, frequently relapsing nephrotic syndrome or SDNS, if the patient is already on low dose alternate steroids, a short course That is 3 extra doses of low dose, that is 0.5 mg per kg per day daily prednisolone at the onset of an infection should be given. This means that the patient is already on alternate day steroids, so you will give 0.5 mg per kg steroid on the days when he was not taking the steroids. So this will make a total of 6 doses in any one week period, initial 1 week period of the infection. If the patient, however, is not on steroids, no prophylaxis with steroids is recommended. Prognosis is best predicted by patients' response to initial treatment and frequency of relapse during the first year after treatment. So renal biopsy is reserved for only patients showing resistance to therapy and having atypical clinical course, and of course for indications which I shall be discussing later. And recurrence risk depends on whether the etiology of the nephrotic syndrome in that patient is genetic or non-genetic. This is something new. This new section has been added by KDIGO. On special situations, renal biopsy is indicated in children presenting with nephrotic syndrome more than equal to 12 years of age, primary SRNS or secondary SRNS, having a high index of suspicion for a different underlying pathology like macroscopic hematuria, systemic vasculitis, hypocomplementemia, etc., kidney failure at onset not related to hypovolemia, and subsequently decreasing renal functions on CNIs or prolonged exposure to CNIs. Genetic testing is indicated in steroid resistance, congenital or infantile forms associated with syndromic features, and family history of SRNS or FSGS. Genetic testing basically helps in identifying monogenic forms which are unlikely to respond to immunosuppression, and renal biopsy is basically a part of precision medicine because it would avoid unnecessary drug exposure to the patient and unnecessary development of toxicity, and it would guide transplant planning, and the recurrence risk is low in monogenic nephrotic syndrome as would be indicated by genetic testing. As regards vitamin D supplementation, it is no longer recommended in patients with steroid-sensitive nephrotic syndrome with normal vitamin D levels. We should evaluate vitamin D levels in these patients with nephrotic syndrome, especially presenting with the initial episode. But in patients with frequently relapsing steroid dependent or those who have a known vitamin D deficiency, oral supplementation of calcium and vitamin D is recommended, and there is insufficient evidence to recommend prophylactic proton pump inhibitors in children with nephrotic syndrome in absence of risk factors for gastrotoxicity or of gastric symptoms. Coming on to 3 different case scenarios, all patients are currently admitted under me. First is a 15-year-old child with recurrent fever for 2 to 3 months. On examination, he had minimal periorbital edema and a routine LFT showed hypoalbuminemia. So we got a urine dipstick done. It was 3+. Renal biopsy was done at the outset since the age of the child was 15 years. This was suggestive of non-proliferative glomerular disease. It might be minimal change, but this was not specified. Steroids have been started and the remission was achieved on day 14. The child is planned for discharge today. One must remember that these patients are more commonly steroid resistant, and if they are steroid sensitive, they might take a longer time to show initial response. Like most of the children with steroid sensitive nephrotic syndrome achieve remission within 7 to 10 days of the initial episode, but this child took 14 days to show remission. The second case is a 6-year-old boy previously diagnosed as steroid sensitive nephrotic syndrome last year, presented with anasarca this year and urine protein 2+ only on dipstick. He had tense ascites. Ascitic fluid examination showed 3000 cells with 70% polymorphs. So a diagnosis of spontaneous bacterial peritonitis has been made. Steroids have to be started after 7 to 10 days of antibiotics after the infection subsides. Now my query is that 2+ protein, is it partial relapse or partial remission? And should or should not we start alternate steroids once remission has been achieved with the treatment of infection alone? Like many a times, for example, this patient is SBP. Once we treat SBP, then the patient might go into remission. So should we start alternate steroids at that time or not? The third case is a 9-year-old girl with steroid-sensitive nephrotic syndrome belonging to an economically constrained family, leading to frequent non-compliance to complete treatment. Dipstick showed 2+ proteinuria. Treatment continued by the mother as long as the patient has edema and low urine output, despite proper counseling every time. So most of the time this happens that parents, as long as edema is visible, they think that the child is sick, and as the edema subsides, maybe with diuretics from outside practitioners or from quacks, they think that the child is okay. They're not worried about the kidney disease per se itself. Incompletely treated episodes, should that they be labeled as frequently relapsing or steroid dependent, even when we consider the time period? This is the main query. And these patients with recurrent courses of steroids, will this lead to steroid resistance? This is another query which needs to be solved. Thank you so very much for a patient listening and watching. If you did like the video, please do give a thumbs up and share the video for the maximum benefit of all. Thank you and thanks a lot.